So good afternoon and welcome everyone. And again, if you can fill out that pre-session survey, it's right there. The link is right there in the chat. And in order to receive CEs and certificate of trainings, I want to welcome all of you on behalf of Project Firstline Rhode Island and the Center for Acute Infectious Disease Epidemiology at the Rhode Island Department of Health in partnership with the CDC. Thank you all for taking time out of your busy day to join me today. And we will be discussing measles in the healthcare setting and review important infection prevention and control strategies. So before we begin, I'd like to direct your attention to the chat. My colleague Allie will be posting information for you throughout the webinar. And at the end of this session, links will be posted for you as your resources, and you'll also be getting them in your post-session survey. So if you all want to take a moment to introduce yourselves and put where you're from in the chat, love to hear from you. And while doing so, also, I'd like to introduce Dr. Kearney. She will be coming on at the Q&A session at the end.
Good afternoon, everyone. Thanks for being here with us. Feel free to ask any questions along the way.
Great. Thanks, Dr. Kearney. And for those of you who do not know me, my name is Lisa Ledoux, an infection prevention training liaison for Project Firstline Rhode Island. I've been a nurse for over 32 years, and my professional experiences have been in many different settings. And even though my nursing roles and responsibilities have varied over the years, infection control and prevention have always been in the forefront of my practice. So again, I'm glad to meet all of you. And for those of you who are returning, great to see you again. Currently, everyone is muted. And as a reminder, this session is being recorded. At the bottom of your screen, you will see the Q&A box. So please use that box for all questions. We will have a brief Q&A session at the end, and we're going to try to address all your questions if time allows. So if not, again, please leave your email so that we can respond to any of your questions you may have now or anytime after the webinar. And the chat box will be available to connect with our behind-the-scenes team members, and we'll use the chat to share experiences and interact throughout the session. All right, we'll get started here. So our agenda for today's presentation, again, we just did our welcome and introductions, and we will be going over our learning objectives. We will review measles then and the current cases of measles in 2024, clinical overview of measles, review vaccine recommendations, go over some infection prevention and control actions, and we have a couple case scenarios we'll go over together, and then go into our key takeaways, and we'll have brief announcements and end of session feedback, and then our Q&A. So once considered to be eliminated from the US, measles has been grabbing headlines again with significant outbreaks around the world. There has been a decrease in vaccination rates, causing an increase in measles cases in the United States. Measles isn't just a little rash. It's an acute viral respiratory illness. It's a childhood infection caused by a virus, and it's also called rubiola. It is very contagious, and it causes a total body skin rash along with flu-like symptoms. It spreads easily, and it can be serious and even fatal for small children. Outbreaks of measles in healthcare settings and transmission to and from healthcare personnel it continues to be reported. And healthcare personnel are considered to be at higher risk for getting measles than the general population. And this is because patients with measles often seek medical care due to the severity of their symptoms. And also, measles is highly contagious and potentially underrecognized with delays in patient isolation and diagnosis. So today we're going to review measles and infection prevention and control actions that you can do in your healthcare role. And here are our learning objectives. We're going to understand what measles is and learn about its resurgence in the United States. Learn how to rapidly recognize measles based on history and clinical presentation. Understand how measles spreads, know the steps to take if there's an exposure with and without proof of immunity, and learn the infection prevention and control actions to help decrease the spread of measles. And again, we're going to review measles. We're going to start with reviewing measles then and now. So before the live measles vaccine was licensed in 1963, an estimated 3 to 4 million people were infected with measles annually in the United States, but most cases were not reported. Most people contracted measles by the time they were 15 years old. And despite being a nationally notifiable disease in the US since 1912, an average of only 549,000 measles cases were reported annually. Of these, approximately 48,000 people required hospitalization, 1,000 developed acute encephalitis, and 400 to 500 people died. In 1968, an improved live measles vaccine was licensed. And then in 1971, the MMR vaccine came out. And the MMR is a vaccine for measles, mumps, and rubella. And then in 1989, the US and other countries around the world saw an increase in cases due to low vaccination rates. And this is because there was a vaccine hesitancy due to widespread misinformation about the vaccine. In 2000, measles was declared eliminated from the United States. And we're going to discuss a little bit more about elimination, what elimination means in the next slide. But since 2000, the annual number of cases has ranged from a low of 37 in 2004 to a high of 1,282 in 2019. The majority of cases in the United States have been among people who are not vaccinated against measles, and most were linked in some way to imported cases of measles. This means that an individual contracted measles when visiting another country. And when they return home, the virus spread amongst their contacts, generally to other unvaccinated individuals. Since measles is so contagious, it quickly and easily spreads in communities with large groups of unvaccinated people. In 2024, we have seen significant increase in measles cases across the country, leading epidemiologists and health departments to worry about sustained measles transmission. The World Health Organization defines measles elimination as the absence of endemic measles virus transmission in a defined geographical area for at least 12 months or longer, and with the presence of a well-performing surveillance system. Measles was declared eliminated in the United States in 2000, meaning there is no measles spreading within the country, and new cases are only found when someone contracts measles abroad and returns. And this was due to widespread vaccination campaigns both in the US and abroad. However, travelers continue to bring measles into the United States, and it can sometimes spread and cause outbreaks among people who are not vaccinated. The term elimination does not mean gone forever, and the rapid rise in cases this year poses a threat to the United States losing its elimination status. So why is measles a concern now, and what is happening? Well, declines in measles vaccination rates globally have increased the risk of larger measles outbreaks worldwide, including the United States. An outbreak is defined as when a disease happens in greater numbers than expected in a particular area. Measles outbreaks have been increasing worldwide, mostly spreading from people who are not vaccinated. Measles cases continue to be brought into the United States by travelers infected while in other countries, and most importations come from unvaccinated US residents or visitors. When measles gets into communities of unvaccinated people in the US, outbreaks can occur. And outbreaks in countries to which Americans often travel can directly contribute to an increase in measles cases in the US. In recent years, measles importations have come from frequently visited countries, including but not limited to the Philippines, Ukraine, Israel, Thailand, Vietnam, England, France, Germany, and India, where large outbreaks were reported. So here's a slide showing the number of measles cases reported by year in the United States. This slide and the next two slides were taken from the CDC measles cases and outbreaks website. And Allie, that's going to be one of the links that Allie will be showing at the end of this session. So as of Friday, April 25th, the US has had 128 measles cases reported in 20 jurisdictions this year. According to the CDC, this is the highest number since 2019. And among that number, 45% were under 5 years old, 81% were unvaccinated or unknown vaccination, and 55% were hospitalized for isolation or management of measles. So there's been 8 outbreaks reported in the US in 2024 so far. So for comparison, 4 outbreaks were reported during the entire year of 2023. So that is double the cases reported in 4 months versus 4 reported in 12 months. And just last week, there was a reported case of measles in Vermont. And this is the first case of measles in 2024 in a New England state. And this graph reflects the number of weekly measles cases by rash onset date reported in the US. So this time frame is from January 1st, 2023 up until March 17th of 24. And you could see the increase in March of 2024. This was updated on April 25th, and rash onset date is currently unknown for one reported case in 2024, but that data is not included in this graph. And next slide. Okay. And here you can see where those measles cases have been reported in the United States, again, as of April 25th. So these statistics get updated weekly on Fridays by the CDC. And again, Allie will show you the site for you to check it out so you can monitor the reported measles cases throughout the United States weekly. Okay, so here is our first poll question. So those of you who are familiar, I invite you to put your answers in the chat. I will ask you the questions. Your answers are anonymous, and you can put the answers in the chat. Measles cases have increased globally due to A, decreased supply of vaccine, decreased vaccination rates, decreased effectiveness of the MMR vaccine, or D, none of the above. So I'll just give you a little bit of time, and if you could put your answers there and see how everybody does here. So measles cases have increased globally due to what reason? Why are we seeing an increase? Okay, let's see. Great. All right. So the answer is decreased vaccination rates. Excellent job. 88% of you said that. So thank you so much for participating. And we'll have a few more poll questions throughout the session. Good job. And next we're going to go over, we're going to review measles infection timeline and the clinical characteristics of this highly infectious virus. So timeline is an essential piece of information to collect when suspecting measles. Let's review the typical timeline one would expect. There's an incubation period of 10 to 12 days from exposure to the onset of early symptoms, also called the prodromal symptoms. And these symptoms can include fever, cough, runny nose, or watery red eyes. And following these prodromal symptoms, the rash begins. The date of rash onset is considered day 0 when talking about measles cases. And on average, the time from exposure to onset of rash is 14 days. And the longest time period is considered 21 days. So people who develop measles are considered infectious from 4 days before until 4 days after the onset of the rash. And the challenging part of measles control is that people are infectious before the rash appears, and they can be infectious when they only have nonspecific symptoms that can mimic other respiratory illnesses. And here are some of those prodromal early symptoms that I mentioned. They could present with fever as high as 104, and it's not uncommon to see fevers as high as 105. And they could also present with at least one of the following, they call it the 3 C's: cough, coryza, which is runny nose, or conjunctivitis, which is red watery eyes. They also have a maculopapular rash, which we'll go over next, and also white dots that are inside the mouth that are called Koplik spots. And here are a couple images of Koplik spots. They're characterized as clustered white lesions that appear inside the mouth. They appear 2 to 3 days after symptoms begin, and they're sometimes described as grains of salt on a reddish background, and they occur prior to the skin rash. And next, these are some characteristics of the rash. It starts at the face, at the hairline, or behind the ears. Then it spreads downward to the neck, trunk, and extremities. Maculopapular, the rash they also will look like small raised or flat red bumps. The spots may become joined, which is they call it coalesce as a rash spread, so they become joined together. The rash is not usually itchy, and it fades in the same order as it appears. Okay, and here's our second poll question. Again, I invite you to participate and answer. And here's the question. It comes up, let's see. What is the typical presentation of a measles rash? Starts at the trunk, then spreads up to the hairline and extremities. Starts at the extremities and spreads everywhere, including palms and soles. Starts at the hairline or face and then moves down to the trunk and extremities, or the rash appears in no pattern. So I'll give you a little bit of time to answer. Okay, let's see how everybody's doing here. Okay, so 10% thought that it starts at the trunk and spreads up to the hairline. 76% of you said it starts at the hairline or face and then moves downward, which is correct. It starts up at the hairline, behind the ears, and then it spreads down to the neck and the trunk. So great job. Thank you. Good job. Okay, next. Here are some common complications of measles. The most common complications are diarrhea, otitis media, which is also known as a middle ear infection, and also pneumonia. These complications can cause substantial morbidity, especially measles pneumonia, which can cause severe disease in infants and immunocompromised people. More severe complications are hospitalizations, which occur 1 in 4 cases. Also encephalitis, it occurs, that occurs 1 per 1,000 cases. And then death, it could occur 1 to 3 per 1,000 cases. And all these complications are more common in 2 age groups, those under the age of 5 and those over the age of 20. Complications are more common among those non-vaccinated against measles. And the last complication at the bottom there is subacute sclerosing panencephalitis, SSPE. It occurs 7 to 11 per 100,000 cases. And this is a very devastating neurological complication that occurs approximately 7 years after a measles infection. And it's more common for those who develop measles at less than 2 years of age. And SSPE is a progressive neurological decline, which generally leads to death within 3 years of onset. So once a person has clinical symptoms of measles, there is no treatment other than supportive care. There are no specific antiviral therapy for measles. Supportive care such as bed rest, fluids, and control of fever are done to help relieve symptoms and address complications. Severe cases for children hospitalized are sometimes treated with vitamin A, and that would be administered immediately on diagnosis and repeated the next day. If there were a vitamin A deficiency, a 3rd dose would be administered. Post-exposure prophylaxis, also known as PEP, it's given within the targeted window. If it's given within the targeted window, it may provide measles protection or shorten the course of the symptoms. People exposed to measles who cannot readily show that they have evidence of immunity against measles should be offered post-exposure prophylaxis. Okay, so again, if they can't show any evidence that they have immunity against it, they should be offered this treatment to potentially provide protection or modify the clinical course of the disease among susceptible persons. So you would either administer the MMR vaccine within 72 hours of initial measles exposure, or administer immunoglobulin within 6 days of exposure. And immunoglobulins are defined as antibodies, and they act as a critical immune response by recognizing the specific bacteria or virus. So who's at risk for measles? People who have traveled internationally in past 21 days, This has been true historically. There have been some cases of local transmission, so not all cases will have a travel history. People who are non-vaccinated or under-vaccinated people. And under-vaccinated people, those are the people that are considered who did not receive the full 2 doses that's recommended. So they could be either in between the vaccination schedule, or they received 1 dose and decided not to get the second dose. Also, people at risk are immunocompromised people with weakened immune systems, and infants under a year old, and also pregnant people. So now let's go over how does measles spread? Well, we know that measles is a highly contagious respiratory illness. So the virus lives in the nose and the throat of an infected person. The virus's primary mode of transmission is by breathing in droplets when someone infectious coughs, talks, or sneezes. The virus can also be spread by direct contact with infectious droplets that enter the air by coughing or sneezing, and those droplets can land on surfaces, and then someone can touch the contaminated surface and then subsequently touch their eyes, their nose, and their mouth, and then they could become infected. The measles virus can remain in the air for up to 2 hours. It is so contagious that if one person has it, that one person could spread it and infect many others. One of the reasons we worry about measles so much is that, again, it is very transmissible. This means that an individual infected with measles can easily spread the virus to others. So in fact, if you look at this picture, one person infected with measles can infect 12 to 18 other unvaccinated people. So again, one person with measles can infect 12 to 18 other unvaccinated people. So let's take a moment to compare that to other infections. Influenza or the flu. It's a common virus that circulates mostly in the winter months. One person infected with the flu can infect 1 to 4 other people. An Ebola virus is less transmissible. In fact, each Ebola patient infects only 1 to 2 others. Now you'll notice that there is some variability in these numbers. The transmissibility of viruses can be affected by a number of factors, including the environment, crowding, the strain of the virus. But most importantly to learn from today's discussion is that these numbers can be reduced substantially by vaccination and other infection prevention and control strategies. We're just going to briefly next just go over vaccine recommendations. The MMR vaccine is very effective against protecting people against measles, mumps, and rubella, and preventing the complications caused by these diseases. So 1 dose provides 93% protection against the measles. 2 doses provides 97% protection against the measles. And for the pediatric population, 2 doses of MMR are recommended, and the first dose is given 12 to 15 months old. And then the second dose will be given at 4 to 6 years old. And for adults without evidence of immunity should get at least 1 dose of the MMR vaccine. Certain adults may need 2 doses. Adults who are going to be in a setting that poses a high risk for measles or mumps transmission should make sure that they have had 2 doses, and they can be given and separated by at least 28 days, the 2 doses. These adults include students at high school education institutions, healthcare personnel, and international travelers. The vaccine is contraindicated for people with severe immunocompromised conditions, such as those undergoing chemotherapy or long-term immunosuppressive therapy. Also, anyone who's had a history of an MMR allergic reaction to the vaccine, and also pregnancy. Okay, here we have another poll question, and I invite you to participate. A person is more protected from getting the measles when they receive 2 doses of the MMR. Is this true or false? So is a person more protected from getting the measles when they receive the 2 doses of the MMR? And let's see how everybody's doing here. And the answer is true. Excellent. You guys rock. You got it 100%. Good job. All right, moving on. We are now going to go over infection prevention and control actions for healthcare personnel and review what healthcare providers should be doing. So measles is most acquired from persons in the household or community, but the spread of measles can occur in healthcare settings. While the most important measure to prevent measles transmission in all settings is ensuring community immunization, measles prevention in healthcare settings requires a multifaceted approach, including these 7 infection prevention and control actions healthcare personnel can take if there is a measles case or suspicion of a measles exposure in a healthcare setting. And I'm going to discuss each of these actions in more detail. Okay, so the first one, ensure healthcare personnel are vaccinated against measles. Individuals who meet any of the following criteria are presumed to be immune to measles if they have written documentation of MMR vaccination. Again, we all know now that the effectiveness of that vaccine is greater when an individual receives the 2 doses. Also, if the person has laboratory evidence of immunity, which would show a positive IgG, or if they have lab confirmation of the disease, or birth before 1957. So before vaccines were available, nearly everyone was infected with measles, mumps, and rubella viruses during childhood. The majority of people born before 1957 are likely to have been infected naturally and therefore are presumed to be protected against measles, mumps, and rubella. If you were born before 1957, chances are you are immune just because there was so much measles going on around that you basically could not have made it through childhood without having the measles. And healthcare personnel born before 1957 who do not have evidence of immunity to the measles should consider getting 2 doses of the MMR vaccine. We want to minimize potential measles exposure. So if measles is suspected, let's start with before arrival to a healthcare setting. Okay, we'll start with that scenario. This is an expected arrival. The healthcare personnel will kind of have like a heads up before this patient arrives. So if someone calls to report symptoms suspicious of measles, the healthcare personnel, you want to triage over the phone and screen symptoms. Get as much information as possible surrounding the timeline of symptoms. For persons with signs and symptoms of measles, provide instructions for arrival. Tell them to avoid public transportation. If they have masks at home, ask them to wear the masks as they make their way to the facility. Minimize the number of people accompanying to the facility. Include instructions as to which entrance to use and precautions to take. And also instruct them that they will immediately be given a mask if they don't come with one. They will be given a mask to wear, and then they will be placed in an isolated private room for evaluation and testing. And healthcare personnel will don an N95 and proper PPE. Okay, now let's think of another situation if measles is suspected upon arrival to a healthcare setting. So this is unexpected. There's no heads up. Someone arrives to the emergency department or urgent care center. You want to utilize existing triage stations for rapid identification and isolation of patients with suspected measles. Persons with signs and symptoms of measles should be identified promptly, and then promptly provide a face mask for that patient to wear. Healthcare personnel will place an N95 on and also any other PPE such as gown or eye protection. You want to place that patient in isolation away from other patients as soon as possible. Facilitate adherence to respiratory hygiene, cough etiquette, hand hygiene, and all your triage procedures. Post visual alerts, posters and signs in appropriate languages about what precautions are being implemented. Provide persons with signs and symptoms of measles with instructions on all relevant infection control expectations. And you want to notify all healthcare personnel of suspected measles. And if there's a situation where this patient does require transfer to a higher level of care, you want to make sure that you have good communication and structure emergency medical services to notify, that they're aware that this patient suspected measles, and then also notifying the receiving facility and accepting physician in advance when transporting a patient with known or suspected measles. Okay, so also adhering to standard and airborne precautions. Standard precautions, which are the foundation for preventing transmission of infectious agents in all healthcare settings. You want to perform hand hygiene, use proper personal protective equipment, assure that that PPE is donned and doffed correctly, make sure the N95 is put on properly, covering the nose and mouth, and it's snug and formed to the face. Follow respiratory hygiene. This minimizes the risk of cross-contamination of respiratory illness, cross-transmission of respiratory illness. And you want to ensure proper placement of the patient in an airborne infection isolation room. And that's also known as an AIIR. Formerly, those rooms were called a negative pressure isolation room. You may still be hearing that also, but an AIIR is a type of hospital room designed to prevent airborne microorganisms in the room from entering hallways and corridors. An AIIR is a single occupancy patient care room used to isolate persons with a suspected or confirmed airborne infectious disease. Another thing you've got to be aware of is cleaning and disinfecting equipment and the environment. EVS should have proper training on cleaning isolation rooms. They should be trained on the cleaning process and pattern, and also the correct cleaning agents to use. Now, airborne precautions. This poster, you can see that on the right side of the slide. This poster may look familiar to a lot of you, but it should be easily seen outside of a patient's room with suspected measles. You want to always clean your hands before entering and when leaving the room. You are going to put on a fit-tested N95 or higher level respirator before entering the room, and remove that respirator after exiting the room and closing the door. And that door to that room should always remain closed. And here are some specifics that fall under standard and airborne precautions. Patient placement. As I just said, you want to immediately place patients with known or suspected measles in an airborne infection isolation room. The patient's face mask could be removed as long as they remain in that AIIR. If an AIIR is not available, transfer the patient as soon as possible to a facility that may have one available. Pending transfer, place the masked patient in a private room with the door closed. The patient should continue to wear that mask for the duration of time spent in a non-airborne infection isolation room. Preferably, the patient should be placed in a room where there's, HEPA filtration. And after the patient leaves the room, it's important to remember it should remain vacant for the appropriate time, up to 2 hours, because we mentioned the droplets can remain in the air for 2 hours. And this allows for 99% of the airborne contaminant removal. Healthcare personnel without acceptable evidence of measles immunity should not enter the room of a known or suspected patient with measles. Healthcare personnel with proof of immunity to measles should be the caregiver of patients with the suspected measles. Healthcare personnel should be using respiratory protections such as an N95 respirator. And again, transporting patients with known or suspected measles within and between healthcare facilities, you want to limit transport of patients with known or suspected measles to essential purposes, such as diagnostic tests or therapeutic procedures that cannot be performed in the patient's room or in the facility. When transport within the facility is necessary, the patient should wear a face mask when they're being, brought down the corridor, use a transportation route and process that includes minimal contact with persons not essential for the patient's care. Notify healthcare personnel in the receiving area of the impending arrival of the patient and of the precautions necessary to prevent the transmission. When transport outside of the facility is necessary, inform that receiving facility and the transport vehicle in advance about airborne precautions being used. In duration of airborne precautions, patients with measles should remain in airborne precautions for 4 days after the onset of the rash. And that's what the onset of the rash considered to be day 0. Immunocompromised patients with measles should remain in airborne precautions for the duration of the illness. You want to manage visitor access and movement within the facility. So if there are persons with measles in your community, consider screening visitors for signs and symptoms of measles before entering the facility. Visitors without acceptable evidence of immunity should not enter the room of a patient with known or suspected measles. And you want to limit visitors to patients with known or suspected measles to those who are necessary for the patient's well-being and care. Implement environmental infection control. And again, standard cleaning and disinfection procedures. Again, EBS should know what disinfectants to use. And also be cleaning and disinfecting frequently touched surfaces or objects for indicated contact times. They would be using an EPA registered disinfectant, and they also be instructed on how to manage used disposable PPE and other patient care items for patients with measles. Disposing of contaminated PPE properly and safely. And number 4, you want to manage measles exposure. So a definition of exposure: an exposure to measles in healthcare setting is considered when spending any time while unprotected, not wearing a mask, in a shared airspace with an infectious patient with measles at the same time, or in a shared airspace vacated by an infectious patient with measles within the prior 2 hours. If an individual is exposed to measles, you want to evaluate exposed healthcare personnel, patients, or visitors for evidence of measles immunity. For asymptomatic healthcare personnel with presumptive immunity to measles, PEP, right, or work restrictions are not necessary. You would implement daily monitoring for signs and symptoms of measles from day 5 after exposure through the 21st day after last exposure. For asymptomatic healthcare personnel without presumptive immunity, you will exclude that worker from work, administer PEP, and then monitor for signs and symptoms of measles. Patients exposed to measles who do not have evidence are placed on airborne precautions for 21 days after the last exposure or until discharge, if earlier. Administer post-exposure prophylaxis and notify public health authorities about patients exposed to measles who have been discharged so that appropriate follow-up care can occur. In the event of an outbreak or exposure involving large numbers of patients who require airborne precautions, you want to consult infection control professionals before patient placement to determine the safety of alternative rooms that do not meet engineering requirements for airborne infection isolation rooms. You may place together cohort patients who have confirmed measles in areas of the facility that are separated from the rest of the patient population, which is important for protecting patients who are at increased risk of infection, such as immunocompromised patients. And use temporary portable solutions, such as an exhaust fan, to create a negative pressure environment in the converted area of that facility to create a patient isolation room. Provide all healthcare personnel with job-specific education and training, including refresher training such as today on preventing transmission of measles. Train and fit test healthcare personnel for respiratory protection device use. And a fit test is a test protocol conducted to verify that a respirator is both comfortable and provides the wearer with the expected protection. And that's the image that you see on the slide right now, that healthcare personnel is being fit tested. And healthcare personnel are fit tested at least annually to ensure that that respirator continues to fit properly. Because each brand, model, and size of respirators will fit differently, healthcare personnel should be fit tested every time that there's a change in the model, type, or size. Also, healthcare personnel, if they have weight changes or any facial or dental alterations, a fit test should be done again to ensure that that respirator remains effective. Ensure that healthcare personnel are educated, trained, and can demonstrate proper competency in the use of appropriate PPE prior to caring for patients with known or suspected measles. Assure healthcare personnel are competent donning and doffing PPE, including an N95 safely. And last, number 7, implement policies that promptly alert key facility staff, including hospital leadership, infection control, healthcare epidemiology, occupational health, clinical lab, and frontline staff about patients with suspected or known measles. Communicate and collaborate with public health authorities. Promptly notify public health authorities of patients with known or suspected measles. Designate specific persons within the facility who are responsible for communication with public health officials and also dissemination of information to healthcare personnel. Okay, so that's a lot of information. So to summarize all those 7 steps, all those 7 infection prevention and control actions that we just reviewed, all of them fall under these 3 steps. So you want to remember to identify, isolate, and inform. So identify is rapid assessment of symptoms, age, recent travel, vaccination status, exposure or contact with known measles. Isolate, promptly isolate. Do not allow patients with suspected measles to remain in the waiting room or other common areas of the healthcare facility. Isolate patients with suspected measles immediately, ideally in a single patient airborne infection isolation room if available. Mask the patient, and the healthcare personnel also will don an N95 and appropriate PPE. Put signage up to notify all healthcare personnel involved with the care of that patient. And last, and just as importantly, is to inform. Immediately notify local or state health departments about suspected cases of measles. For healthcare personnel in Rhode Island, immediately notify the Rhode Island Department of Health about any suspected cases of measles to ensure rapid testing and investigation. Measles is an immediately reportable disease in Rhode Island, which means providers must call immediately upon suspicion. And you will call 401-222-2577 during normal business hours, Monday through Friday from 8:30 to 4:30. To report a suspected case after hours or on weekends or holidays, you'll call 401-276-8046. You can call and speak with a nurse if you have any concerns about measles. You can call to discuss testing protocols and procedures. Ask about the reporting process, or if you have any other questions. They are great and they offer fantastic support and information. And again, these numbers are being shown in the chat, and they will also be at the end of this session with the resources. Okay, I think we have a couple more poll questions here. Have you all participate and answer the questions? And let's see, here we go. A patient presents to your healthcare facility with suspicion of measles. What immediate actions should the healthcare personnel perform? Swab the patient for measles, have the patient take a seat in the waiting room, provide a mask for the patient to wear and place in a private room, or report suspicion of measles case to the to the state health department. So what a patient presents to your healthcare facility, what immediate actions would the healthcare personnel take? Give you a little bit of time here. And we'll see how everybody did. Excellent. You all got 100%. Yes, provide a mask for the patient to wear and place them in an isolation room. Excellent job. And we have, let's see, we have another poll question. Good old knowledge checks here. What precautions should be used when caring for a person with measles? Standard and enhanced barrier precautions, standard and droplet precautions, standard and airborne precautions, or standard precautions only? So again, I'll give you a little bit of time to answer. All right, let's see how everybody did.
Few more seconds. It looks like some more answers are coming in.
Oh, okay. Thanks, Allie.
It's okay.
So what precautions should be used when caring for a person with measles? Okay, 17% said standard and droplet, and 83% standard and standard and airborne precautions. And the correct answer is standard and airborne precautions. Great job, everyone. Thank you. Fantastic. And we're gonna, before we end the session, we do have a couple of case scenarios. So let's, I ask you to participate. You could, so these questions I'll be asking after I give you the scenario, you could put the answers in the chat, okay? Here's our first case scenario. A 23-year-old male arrives to the emergency room with complaints of fever, cough, and watery eyes that started at the end of his college spring break. The healthcare personnel noted small raised spots at the patient's hairline. What are some immediate questions that the healthcare personnel should ask the patient? So if you could put your answers in the chat. So this 23-year-old shows up. What are some immediate questions that the healthcare personnel should ask this patient? Let's see, vaccine status. Excellent. I'm trying to move this over. I'm sorry. Let's see. Yeah, have you been vaxxed with measles? Anyone? Yep, anyone in his surrounding possibly has measles. Travel status. You know, where did he travel to? Where did he go on spring break? Vaccine status. You guys did a great job. Yes, all excellent answers. Yeah, you got most of them? You got all of them. Great job. And here's our next question with the same scenario. What are some infection control actions the healthcare personnel should take with this gentleman that showed up? So he shows up and now you're suspecting it. What are things? Mask the patient. Excellent. Move him to a private room. Give mask in a private room. Yep. You guys got it. Isolate the patient. Call the Department of Health. Yep. And mask. Absolutely. So immediately you are going to you would have this gentleman put the mask on. And what else though? The healthcare personnel also has to put on the N95, right? And appropriate PPE. And if you isolate them, you want to keep that door closed. What about posting signage? You want to have those precaution signs, right? Visibly out there outside the door, and ensure that healthcare personnel has been vaccinated. Make sure, excellent. Yep, you got it. Make sure that the healthcare personnel taking care of the patient is vaccinated. Excellent. Airborne precautions. Good job. You guys did great. Thank you so much. And we have one more case scenario. All right. A mother calls the pediatrician's office to report her 3-year-old daughter has had a fever of 105, accompanied by cough and runny nose. She reports her daughter's symptoms started a few days after they returned from Disney. Okay, so what are some telephone triage questions to ask the mother? So, okay, now you got your heads up, right? The mom's calling the office to report. So what are some triage questions? Excellent. Yes. Does she have a rash? Yep. We're going to ask her if her child is showing a rash. Perfect. Has she been vaccinated? Right? Because she's 3 years old. So she would have already received her recommended first dose. Excellent. Has there been exposure? Yep. You guys, all great answers. Also, ask the mom to look inside the mouth. Does she have the Koplik spots? Right? Any additional household members sick? Very good. Does she have younger siblings? Excellent, you guys. Definitely good critical thinking. Perfect. And one more question on this scenario. What pre-arrival instructions should the healthcare personnel give the mom? So now you're concerned, you feel that this is measles, right? So what are you going to instruct to the mother? Excellent. Patient and mom to wear a mask. Yes. If they have it, please put it on, right? On your way here. Mask. Yep. Wear a mask. Also, do we want her to take public transportation? No, we want to make sure that she is coming to you, right? Your instructor come to that facility and that she is using a private car. Avoid bringing other family members, right? Any other siblings, unless they are symptomatic too. And also you want to give her specific instructions on what entrance to use when she gets to the facility. And also, let her know what she's going to expect when she shows there. If she doesn't have a mask, that she will be given a mask and her daughter will be given a mask and that they will go inside a private room. You guys did great. I thank you so much for your participation. We're next going to go over the key takeaways from today's presentation. You guys, I really appreciate it. Thank you. So measles is a highly contagious febrile illness that can cause serious complications and may result in death. Identifying measles early is critical to preventing the spread of the virus. And the most important action to prevent the spread of measles is vaccination. Suspected cases of measles should be masked and isolated while medical evaluation is performed. And healthcare personnel should follow standard and airborne precautions when caring for an individual with measles. And here are some great posters for you to download and you could print and share with your colleagues, your staff. The poster on the left is identifying a rash and how to protect against infection. And the poster on the right, it's a great summary of 6 key points regarding measles, and the images are there for you for reference for identifying a measles rash. And again, Allie will have all these links at the end so you guys can have them. They'll also be in your post-session resources also. So at this time, if you did not enter your email earlier in the chat box, please feel free to enter it now so you can be added to our distribution list of upcoming trainings. You can also click on our live events link, and that site will be shown also at the end for you to register. And also follow Project Firstline on social media. We are on Twitter, Facebook, Instagram, and LinkedIn. We are excited about our upcoming sessions. And let's see. Next slide here. So next is going to be cleaning and disinfection. It's a deep dive for EVS personnel. Part 1 is going to be presented on May 13th at 12 noon. And then part 2 is going to be presented on May 16th at 12 noon. And it's going to be presented by my colleague, Allison Thurber. CNE, CE, and certificate of trainings will be offered. So please share this with your colleagues. And again, if you could pre-register, we would love to see you do that. And here are the references used for today's presentation. And again, as a reminder, if you, in order to receive certificate of training, you would need to complete that pre-session survey, which was at the beginning. You all participated in the session today, which I appreciate. And then we ask that you complete the post-session survey. And a link for the post-session survey is going to be sent to you via email tomorrow, April 30th. And it will be available until May 6th at midnight. So once you complete the requirements, a certificate of training will be emailed to you in PDF form on May 9th. And for EMS and dental providers, this can be used towards 1 hour of contact ed credit. And also, I believe probably tomorrow you'll be getting a copy of this PowerPoint with all of our resources and references on there. So I ask that you please take a quick few minutes here to complete our end of session feedback. This helps us to improve future trainings and to suit your learning needs. We really appreciate it. And we thank everybody for joining us today. I really appreciate your participation and know it's a lot of information. Again, very, very important. And thank you all who have put your emails in the chat. We will have those all on record there. Thank you. Take care, everyone.